welcome everybody to today's hearing to ensure the Department of Veterans Affairs is meeting the needs of women's veterans. Today, women make up more than 11% of the veteran population. The number is projected to be 15% by 2035, with women making up 17% of the active duty military force and 21% of the reserve component. We know that these numbers are going to grow. With that in mind, the committee has worked in recent years to ensure the VA is providing equitable, high-quality care to women veterans. In 2021, the Deborah Sansom Act, a bill which I led with Senator Bozeman, was signed into law. It continues to help eliminate barriers to health care and services faced by women veterans, including survivors of military sexual trauma. Though MST impacts both men and women, I hope today's hearing will address what the VA is doing to improve care and benefits provided to survivors of MST. I'm encouraged by VA's improvements to its MST claims process since the passage of the Deborah Sampson bill, but I won't stop fighting until all MST survivors have access to fair claims process and high-quality care that they have earned. That is why I continue to push for passage of my bill with Senator Murkowski, the Service Members and Veterans Empowerment and Support Act. This bill would expand the evidentiary standing for MST survivors applying for VA disability benefits. Today, I also look forward to hearing updates from the VA on another critical law, the MAMO Act, another bill that I led with Senator Bozeman to expand veterans' access to breast cancer screening and care. That law includes a pilot program on telescreening mammography services that will give us information on how to best streamline care in rural states like Montana, where the VA doesn't offer in-house mammography services. The MAMO Act and Deborah Sansom Act represent great strides in improving health care and benefits provided to women veterans. We know that our work is far from done, and that's why we're lucky to have a second panel with us today, made up of entirely women who have served our country, including Dr. Alyssa Engel from the great state of Montana. We'll hear from these women about the VA, about where the VA is succeeding in meeting the needs of women veterans and where they need to improve. Women veterans, including rural women veterans and those with specific needs like spinal cord injuries, need our support. So I do want to thank all the witnesses that are here today. And with that, I'll turn it over to my friend, colleague, the ranking member, Senator Moran.
Chairman, thank you. I'm pleased to be here today, and this is an important topic, and I'm glad we're having this hearing. I welcome our witnesses and everyone who's gathered here for this hearing on the needs of women veterans. Women have made immense sacrifices to honor and honorable service to their country since the American Revolution, but far too often their contributions go unrecognized and often underappreciated. A single hearing is unlikely to fully capture the complexity of this topic, but conversations like the ones we will have this afternoon are important pathways to make certain that women veterans and their service are recognized, appreciated, especially when they need access benefits and services from the VA. Our witnesses will share with us in a few minutes, I'm sure, that the VA has made strides to be more welcoming to women, to make gender-specific services to women more accessible. As you said, Mr. Chairman, the work is never over. We say that frequently, perhaps every hearing, every topic that we're involved in. But I would indicate that's true today in this hearing, and it's particularly true when it comes to women serving and who have served, who are now living in rural areas, and aging women who have unique needs the VA must proactively address. In preparation for today's hearing, we reached out to women veterans in Kansas to learn about their experiences. These women told me how grateful they are for the VA and that they have seen VA change for the better over the last several years. Each had similar stories, however, about the challenges that still exist for women. One told me that the only time she hears from the VA is when they're reminding her to pay a bill. Although this woman is an active user of the VA healthcare system, she has still not had toxic exposure screening and had to seek out on her own information about the PACT Act. Because Kansas is such a rural state, women veterans either rely on community care or have long distances to travel to a VA, which they sometimes cannot do because of family and professional obligations or poor health. Each veteran we talked to said the VA has made accessing community health care difficult, even for services like maternity care, which is only provided in the community. One woman had to find a new doctor for her third pregnancy because her prior one was no longer willing to work with the VA. Though though hearing directly from advocates is certainly valuable, and I look forward to that today. I hope today's hearing will shed light on how the VA and perhaps this committee and the Congress can do more in moving forward for women everywhere. Our duty is to make certain that they receive the support and care they deserve, and I thank you, Mr. Chairman. I thank our witnesses.
Thank you, Senator Moran. I want to welcome our first panel witness to this afternoon's hearing. I will introduce you right now. From the VA, we have Dr. Erica Scavella, Assistant Undersecretary for Health and Clinical Services at the Veterans Health Administration. She is joined by Dr. Sally Haskell, Acting Chief Officer for VA's Office of Women's Health, and Dr. Amanda Johnson, Acting Deputy Chief Officer for the Office of Women's Health. Also from the VA is Kenesha Britton, Assistant Deputy Undersecretary in the Veterans Benefits Administration Office of Field Operations. And finally, last but certainly not least, from the VA Office of Inspector General, we always appreciate having the Inspector General here. We're joined by Dr. Jennifer Baptiste, Deputy Assistant Inspector General in the Office of Healthcare Inspections. Dr. Scavella, we will start with you.
Thank you.
Know your entire written statement will be a part of the document. We'll try to hold it to 5 minutes. Thank you.
Thank you, sir. Good afternoon, Chairman Tester, Ranking Member Moran, and committee members. My name is Dr. Scavella, and I'm the Assistant Undersecretary for Health for Clinical Services in the Veterans Health Administration. Joining me today are Dr. Sally Haskell and Amanda Johnson, respectively the Acting Chief Officer and Acting Deputy Chief Officer within the Office of Women's Health. I'm also accompanied by Ms. Kenesha Britton, who is the Assistant Deputy Undersecretary for Benefits for National Contact Field Operations within the Veterans Benefit Administration. Thank you for the invitation to testify before you today. Addressing the unique needs of women veterans is crucial. Since 2001, the number of women using veteran services has tripled, going from 158,000 to over 625,000 enrollees within the last calendar year. As we wrap up our 100th year of providing women's health care, we aim to set a higher standard of care and become a national leader in women's health care. We proudly provide comprehensive care for our enrolled women and gender-diverse veterans, including preventive, acute, and chronic disease management, reproductive health care, and mental health care. To address gender-specific health concerns, we have developed several primary health care policies, one of which includes assigning a woman to a trained women's health primary care provider, should she choose to have that. As of September 2023, all healthcare systems have at least 3 primary care providers who are specializing in women's health. A major component of the comprehensive care that we provide includes a range of essential reproductive health services, including contraception, pregnancy-related care, fertility counseling, sexually transmitted infection screening, and specialty medical and surgical management of gynecological conditions. VA provides comprehensive and specialized gynecological care through a network of skilled professionals at state-of-the-art facilities. Initiatives like the Gynecology Community of Practice and virtual grand rounds enhance the quality of care. Access to essential reproductive care, including abortion care, is vital for our patients if they are experiencing a condition that may affect the life of the veteran. VA is dedicated to supporting women veterans' mental health needs and well-being through a range of initiatives. This includes expanding access to evidence-based services, increasing awareness of gender-specific resources like women-only therapy and women-led peer support groups. Specialized care is offered for conditions like post-traumatic stress disorder, depression, anxiety, and reproductive mental health issues like postpartum depression. VHA additionally offers innovative resources to support clinicians, including a national network of women mental health champions at each VA medical center. VA has trained over 120 clinicians since 2022, specifically in women's health. VA is dedicated to ensuring that every woman veteran receives the benefits she deserves and continuously expands its outreach and services to better support women veterans. The department recently organized nearly 140 events tailored specifically to meet the needs of women veterans and provides a web-based course to enhance that education. Thanks in part to this effort, we have over 702,000 women who are currently receiving disability compensation benefits, setting a record with a 26% increase over the past 5 years. Finally, We recently implemented various reforms to improve the military sexual trauma, or MST-related claims process for both male and female survivors. In fiscal year 2023, we had over 43,000 MST-related claims that were processed, with women receiving 62% of the MST-related benefits. Ongoing work is being done to address underdevelopment, examination, and medical opinion-related errors, and improper denials. To ensure timely decisions for MST survivors, VA is reaffirming its commitment to enhancing workload management strategies, increasing full-time employees at our operation centers, analyzing trends and common errors, and conducting a claims quality stand-down day for our MST claims processors. Our commitment to ensuring that women veterans receive the care, support, and respect they deserve remains unwavering. VA's women-centered programs have made significant strides in improving their well-being, especially as their enrollment within VA reaches new levels. We must maintain this momentum and protect the progress achieved through our continued collaboration. Thank you so much for this opportunity to update you on our efforts, comprehensively providing care for women veterans. Chairman Tester and Ranking Member Moran, this concludes my testimony, and we are ready for your questions.
To the second, and I assume Dr. Scavella, Britton, Haskell, and Johnson are with you, and we will now hear from Jennifer Batiste.
Chairman Tester, Ranking Member Moran, and committee members, thank you for the opportunity to discuss the OIG's oversight of VA programs and initiatives that focus on serving women veterans. The OIG's Women's Health Program was implemented to help ensure VA is meeting the healthcare needs of this expanding population. More women veterans are accessing VA at a younger age, underscoring the need for maternity and gynecologic care to be readily available. Access to gender-specific cancer screenings, such as for breast and cervical cancer, and diligent follow-up of test results are necessary. Women often present with unique symptoms for acute and chronic health conditions such as cardiovascular disease. VA must ensure its care providers are equipped to detect and manage women's distinct healthcare needs. Also, expanding outreach and screening for MST and mental health conditions could make more eligible women veterans aware of the care and benefits available to them. Our work has found that frontline VA staff are overwhelmingly dedicated to providing high-quality care to women veterans. We recognize the commitment VA has shown in increasing the availability of gender-specific resources while working to create a safe and welcoming environment. As the number of women veterans continues to rise, however, VA faces significant challenges in ensuring access to women's primary care providers and gender-specific care within their facilities and in the community. Recent OIG reports on VHA women's health providers, the mammography program, and reproductive health services highlight several areas for which improvements affecting gender-specific care are needed. Those reports have highlighted that there is still important work to be done on maintaining a welcoming environment and access to clinicians that are fully supported and trained in treating women veterans. We have reviewed and substantiated allegations of inappropriate conduct by a gynecologist and lack of advocacy by a chaperone. We have also confirmed that a facility women's veterans health care program was under-resourced and largely overlooked. Failures of the type the OIG has reported can undermine women veterans' trust in VA. Coordinating care that women veterans receive in the community is also critically important because some gender-specific care, such as maternity care, is not generally provided within VA facilities. Women veterans may also be referred to the community for gynecologic care and cancer screenings. Test results, therefore, must be timely communicated and medical records returned promptly back to VA. VA program coordinators who support the care of women veterans, including maternity care, MST, and intimate partner violence coordinators, largely do so as collateral duties. They have reported to OIG that they often lack sufficient resources, administrative support, and protected time to effectively serve women veterans. Other related OIG oversight work has demonstrated the importance of appropriate screening and support for victims of sexual violence, as well as the need for MST benefits claims to be processed more accurately and timely by VBA. We recently released a report that found approximately half of the veterans who reported sexual assault to DOD while on active duty did not use VA healthcare, and a third had not received a service-connected disability rating, suggesting the need for better outreach to veterans and ensuring a welcoming environment for those veterans to receive care. In closing, the OIG's portfolio of work to date highlights the challenges VA must overcome if they want to engage more women veterans who will rely on and trust VA for their care. The OIG Women's Health Program is currently conducting a national review to assess maternity care coordinators' workloads and fulfillment of their duties, with a follow-on review that will include the experiences of veterans who have received maternity care coordinated by VHA. Additionally, the OIG audit staff continue to monitor the processing of MST claims for VA benefits that have disproportionately affected women veterans. We will continue to monitor VA's progress on addressing the needs of women veterans and to provide practical and meaningful recommendations for improvements. We appreciate the opportunity to participate in this hearing. It is fitting that this hearing falls during the month VA highlights sexual assault awareness and prevention. The OIG is committed to being a voice for survivors and providing VA with information to improve its efforts. Chairman Tester, Ranking Member Moran, and members of the committee, this concludes my statement. I would be happy to answer any questions you may have.
Dr. Baptiste and Dr. Scavella, thank you both for your testimony. We appreciate it, appreciate your work. I will turn to the dean of this committee for her questions. Senator Murray.
Thank you. Thank you. Really an important topic because we all know that women are the fastest growing demographic within the veteran population. In my home state of Washington, the Puget Sound VA saw a 7% increase in women veterans who are using their services over the past 2 years. In February, I met with women veterans in Seattle who told me about the barriers that they are facing in receiving health care through the VA. I heard from a veteran who she was looking for care at American Lake VA, which was very close to where she lived, but the women's clinic was completely full. So she had to go to the Seattle VA to get care, and close but not close. And I know a lot of other women veterans are facing the same stories. Her story is not unique. I hear that all the time. Many women are having the trouble getting the care that they need. And additionally, mammography services are an important part of health care for women veterans. But right now, in VISN 20, which covers Washington, Oregon, Idaho, and Alaska, is the only VISN without in-house mammography. And that is really not acceptable. So Dr. Scavella, does the VA have plans to expand their in-house mammography services to VISN 20?
Thank you for that question. We are always aiming to provide services at the point of care where veterans find it most convenient and most accessible. We do face challenges just like the rest of the United States in having qualified employees to provide these services. So that is a challenge for us, but we will continue to work to make sure we have services that are accessible within your systems. There's also a quality of care component related to providing mammography in that you need to make sure that the mammographers, the persons performing the procedures, are adequately trained and are able to keep their skills. So I can look specifically into any of the demographics there. I would like to ask Dr. Haskell if she has any specific information to answer your question.
Okay.
Yes, thank you, Senator Murray, for your question. VA currently has in-house mammography at 78 sites, and it's really been increasing very rapidly over the last number of years, and we are looking at additional ways of providing mammography, as you probably know, through teleradiology, as well as potentially looking into more mobile mammography services. So these are some things that the National Radiology Program is working on. I think, as Dr. Scavella says, we are limited in that we want our mammography programs to be very high-quality care, and in order to do that, we need to ensure that there are a certain number of women at a facility. There are requirements, both for the radiology technologist and the radiologists themselves, that they need to do a certain number of cases per year in order to be qualified and certified. So we look carefully at those numbers, and we are also, I do want to say that we're very aware of that VISN 20 gap, and I know that the radiology program is looking at it very carefully.
Okay, if I could just ask, can you take a look and get back to me and tell me if you're not going to do it, or if you are, when it's going to happen? And I want it to be the answer to the second question, not the first there. So
Absolutely. Thank you.
Thank you. Earlier this year, DOD announced that it's going to expand its IVF services to single and unmarried service members and will allow service members to utilize donor gametes. I was really excited to hear that the VA is following DOD's footsteps in its IVF expansion. This is really great news for active duty service members and veterans, and I know we have a lot of work to be done to make sure everyone has the access they need, which is exactly why I introduced the Veteran Families Health Services Act, which will expand IVF services to more service members and their families, and I'll be working very hard to get that passed. But Dr. Scavella, if you can just talk about how this recent expansion will help more women veterans and speak to why IVF care is so crucial for veterans who cannot conceive naturally.
Thank you for that question. It's fitting, again, that we're having this hearing 1 month after Women's Women's History Month, and it's 1 year and 1 month post the Secretary providing a new mission statement, which includes women in the mission statement. We now can offer IVF services to women veterans who may be unmarried, veterans in same-sex marriages and other non-marital unions. And we can also now use the gametes, the embryos and eggs and sperm from donors as opposed to previous legislation and rules and regulations. So it has expanded the opportunity for us to provide that care. We're really excited by the release that the Secretary signed last month, as well as the entry into the Federal Registry.
Well, thank you. And Mr. Chairman, I will just say that when we ask our men and women to serve our country, we tell them we will take care of them when they go home. To tell them that doesn't include having a family, to me, is outrageous. So I think this is really important, and I appreciate the work you're doing on it, and we will continue to do everything we can to make sure we get this done for families. Thank you.
I agree with you, Senator Moran, and I also appreciate your work. Senator Moran.
You agree with Senator Murray? That's what
That's what I said. I said I agree with Senator Murray.
Oh.
And appreciate the work of the VA.
Me.
I do occasionally agree with you, too,
All right.
Senator Murray.
Dr. Scavella, one of the women that my staff spoke to, woman veteran, in preparation for this hearing, is being reassigned a new primary care provider as her current one is retiring. She is concerned she will be assigned a male physician. On the other hand, on my way to the airport on Monday, I stopped unannounced at a VA clinic in Kansas City, Kansas, and visited with the veterans in the lobby. And this female veteran was telling me that she's getting good care, but she'd prefer just to be treated as a veteran, not a woman veteran. My staff tells me that's not an unusual circumstance, and in the view of this woman, she believed that she was not offered that opportunity. She was only eligible for care on the women's clinic side of the VA. So, my understanding now is that that's not the case. I don't know what the educational or comments were made to this veteran in the waiting room, but in each instance, they're looking for a specific kind of provider. One, just the general VA, and one would really like to have a woman doctor. Tell me how this works at the VA.
Yeah, so thank you for that question, Ranking Member Moran. I am a 25-year veteran of working within Department of Veterans Affairs, and I took care of women and men in Baltimore and was very proud to do so. I had some women who wanted to see whomever they could and did not have a preference, and I had some women who specifically wanted a specific gender, whether it was a male physician or a female physician, and it is their choice. We are currently, in this current day, we are required to offer women veterans the opportunity to have the clinician of their choice. They can choose a woman, they can choose a man, and we continue to do that. It is their choice, and so we find some who really feel really safe in those sex concordant relationships for their provision of care, or there are some that don't have a preference. We just need to make sure we meet their needs.
Doctor, this committee has been attempting to help the VA solve its provider shortage, and we just heard about that in mammography. Is there a shortage in doctors who are female at the VA? So if you ask for a doctor who's a female, is that a given?
So I think we do reflect the U.S. Population for women who are in medicine. We may be a little still discordant as far as having how many women. I'm going to actually ask Dr. Haskell if she knows that number, but I don't think so.
Yeah, I think, first I did want.
Push the button.
Excuse me, is that better? Yeah.
Much better.
I did want to say that in regard to, well, first of all, let me answer your question, which is that I do believe that more than 50% of the providers in VA, at least in primary care and in mental health, I believe are female. So we don't have a shortage of female providers. But I did want to say in regard to women being able to have a choice of providers that we require that all women are offered assignment to a women's health provider, but our goal is really to have at least 85% of all women assigned to women's health providers. So it means that we are taking into account the fact that there will certainly be some women who prefer to be assigned to a regular primary care provider, not in a specific women's clinic.
I didn't know exactly how to ask that question,
Yeah.
what the right words were, but I can assure, this testimony will assure the veteran I visited with that she has the choice, and
Yes.
even if it's offered, it doesn't have to be accepted.
Exactly.
Great.
That's correct. Thank you.
Let me talk a moment about a kind of a common complaint, and that is the community care. And it's at least the veterans we visited with are concerned that the doctors, the providers are not being paid in a timely fashion. They're taking away the opportunity to provide community care to veterans. In many places, we need to be growing community care, in particularly rural places. And with maternity care only being provided within the community, are we cognizant of the fact that we need to make sure that community care works for the provider and for the veteran? In other words, are we caring for the timeliness, the timeliness of payment, those kind of things that make community care still a viable option in places across the country for maternity care and for places across rural America for veterans and their wide array of need for medical services?
So thank you for that question. Since I see we're at time, I will actually defer to Dr. Johnson for that answer.
Dr. Johnson.
Yes, thank you very much. I think that's an important concern and a critical concern. And absolutely, our maternity care is provided entirely in the community. And the reason for that is we cover about 7,000 deliveries across our large integrated healthcare system. And in order to provide high quality maternity care, we really require enough volume to provide that care in a safe manner. So if we're doing 7,000 deliveries a year across a large integrated healthcare system, we just don't have enough volume to build that infrastructure within VA, which would include neonatologists, NICUs, neonatal intensivists, all of those things that we need to have in place to provide care, safe maternity care. And I, as an OBGYN who actually works in a rural area, am well aware of the needs of women in those states. And what we have as a healthcare system is a priority to ensure that our community care networks are adequate so that we are able to provide that care to the veterans we serve no matter where they live. And then also leverage our telehealth ability that we have within our healthcare system to provide our veterans with tablets that have broadband access, so even those folks in rural areas are able to connect with their providers remotely if that's possible. Now, for some OB care, that has to be done face-to-face, and we're aware that for folks living in rural areas, they may need to travel for some of that. One of the programs that I'm very proud of is our maternity care coordination program, and Dr. Baptista mentioned it a little bit. We work quite closely together when we look at whether our maternity care coordination program is meeting the needs of the veterans we serve. But that program was developed to recognize that we have veterans who are using maternity care who are automatically getting dual care, meaning they get care in VA for their mental health care, their primary care, and they must be getting care in the community. So it's really critical to have that care coordination piece that works to center the veteran and their needs with both their community provider and their VA providers.
Dr. Johnson, thank you. You've testified before us before, and I appreciate your testimony. Senator King, I'm sorry that Senator Tester allowed me a third question, and then I'm leaving to return to Intelligence Committee where you and I came from. Yes. Ms. Britton, 2018 VA Inspector General report found that 49% of military sexual trauma claims were not properly processed. The result of that was that veterans, according to the Inspector General, were being prematurely denied benefits they were owed. In 2021, the IG followed up with recommendations and found about 57% of denied MST claims were still not being properly reviewed. It doesn't seem that the VA has this right yet. Can you explain how the percentage of MST claims being improperly processed increased by such an alarming percentage after the 2018 IG report, and what VBA is taking, what actions VBA is taking to make sure it doesn't continue?
Thank you, sir. First and foremost, I would like to say that we do recognize the declination in the accuracy rate of the MST claims processing. As a result of the 2021 IG report, we did centralize our claims processing to specialized sites to process our MST cases. With those cases being centralized, we provided specialized training to those claims processors to ensure that they have the necessary technical knowledge to be able to process those MST cases. We started out with 5 sites to process those cases, and we most recently centralized to 1 location under 1 senior executive with those specialized claims processors. We have within our receipt the special focus review that yielded a 71% accuracy rate for FY23 for MS Teams claims processing. What centralizing the claims has done for us is it's allowed us to really hone in on the errors that we've seen in the claims process. With the special focus review, we took a deep dive into that, and we are revamping how we're doing quality. So we generally look at our employee quality, which is 97%. With the 71% that was achieved on the special focus review, we actually took a step back and we modified how we're assessing our MST cases. Now we will begin looking at those MST cases and the accuracy level of those on a monthly basis as opposed to an annual basis, which is what we've traditionally done as directed in the OIG report. This would allow us to do 3 reviews at the employee level, which also expands the number of reviews that we're doing annually. So with that special focus review, we did a little bit over 200 reviews. This would give us the opportunity to look at 15,000 of those MST cases to make sure that we're assessing the accuracy of those in flight. So we'll no longer be waiting until claims are completed to look at whether or not they are done right. We will do in-process reviews along the way, and instead of doing that at the claim level, we will do that at the employee level to make sure that those employees are being trained properly. We are looking at our top error trends. We are developing targeted training to make sure that those claims processors have that training. And I am happy to report that even though we have seen that 71% accuracy rate, we have seen an increase in the grant rate for our MST survivors. So we've seen a increase in the grant rate from 2011. It was at 56%, so we're now looking at 62% for our grant rate for our MST survivors.
Ms. Britton, it'd be unfair to my colleagues to ask any follow-up questions, but perhaps we can, after the hearing, my staff and you can have a conversation and or we can have a conversation elsewhere. But we'll follow up with you. Thank you.
Absolutely. Thank you, sir.
You're welcome.
Senator Angus King.
Thank you, Mr. Chairman. I'd like to thank the chairman and the ranking member for this hearing. I think it's such an important topic and important for our focus. Ms. Britton, I've heard a lot of testimony. That answer you just gave is one of the best and most clear, concise, and informative answers that I've ever heard in this committee. So thank you for that. Dr. Scavella, I think it was Dr. Baptiste that mentioned only half of the MST victims use VA care. It seems to me that just cries out for outreach. Talk to me about how do we increase that number, because it's a tragedy if there are people who need care, the care's available, but they never ask, they never knock on the door. What are we doing about outreach?
Thank you for that question, Senator King. So one of the things that Deputy Secretary Bradsher is very concerned about is making sure that women veterans feel that they have a place within VA to receive their care and that they are coming to us for that care. We know.
Is there a perception among women veterans that the VA is male-dominated, it's a service mostly for male veterans?
I would say from the perspective of many, including some anecdotes that I've heard from her and others, that some women who have served don't see themselves as veterans, they don't see themselves as having a place here or deserving of receiving the services that we can provide, both through VHA, VBA, and NCA through the cemetery services.
Let's go back to outreach.
So back to outreach. We are involved with the TAP program that takes place within the 1 year post and pre-separation from the service.
When it happens, sometimes it doesn't happen.
Correct.
That's
That may
between
be-
me and the Defense
Yes,
Department.
I was going to say, I can't comment on what's happening at the Department
I
of
got
Defense,
it.
but the VA is actively engaged with trying to improve the TAP program to make sure that we have a presence. The Women's Veteran Services programs and things that are available to women as they're separating are presented at that. There's a separate session for them to hear about what we have. So we are actively trying to make sure that they know that they have a place here. The other thing I will say is that we do know that approximately 1 in 3 women veterans have experienced military sexual trauma. Approximately 1 in 5.
It's an appalling number.
Correct.
And it's probably underreported.
Correct, probably underreported. Approximately 1 in 5 have experienced intimate partner violence. So between those two and just the burdens on women in general, we are working really hard to make sure that when they do come into our system, that we are proactively screening them, bringing them in for services, connecting them to mental health care, which can be either a risk factor for those two, or they could be things that develop after having experienced.
I would hope that you might develop an additional special outreach over and above the TAP program, just a letter, some kind of communication, but even before mustering out, so that women veterans know that there is a place that they can go. Let me move on. We're dealing with particularly MST and other issues that are involved with mental health issues, stigma, PTSD. How are we, I guess the first question is, do we have the capacity in terms of mental health professionals to deal with these issues? Because I know in my state of Maine, there's a problem of mental health professionals generally, let alone in the VA. Where do we stand on that score?
Thank you for that question. So we do have specific mental health coordinators at each facility that can help our veterans with that. We also do have a variety of outreach programs that Women's Health Office is actually leading. So we are doing all of those things to make sure that they are receiving the care. I'd love to allow Drs. Haskell and Johnson to add to my answer.
Well, one thing I hope, behavioral health lends itself to telemedicine. And we found in the private sector that it increases people's attendance at their appointments, less stigma. They don't have to sit in an office and worry about who's next to them. So I hope that's one of the options that's being pursued.
We are using telehealth, yes, thank you.
Yeah, if I could just make a few more comments about outreach. We do have a very robust outreach program through the Office of Women's Health, through our Women Veterans Call Center, where we make outgoing calls to women veterans and women veterans who are not using VA to inform them about benefits and services that are available. and that's been in existence since 2013, and I think we've called over 2 million women veterans, or made over 2 million phone calls. So that's a very effective program. And then you were talking about the TAP program, so there's a women's specific module called the Women's Health Transition Training. It was actually developed by our Office of Women's Health in conjunction with DOD and VBA, and has now been taken over by VBA and is available to all women. And that's a session that's fully devoted to educating them about the benefits and services that are available specifically to women.
I'm going to have a suggestion, Dr. Scavella. When I was governor, I used to occasionally call the state's 800 numbers. My chief of staff called it scaring the staff. But it would be informative for you to check, and also to have kind of secret shopper, you know what I mean? So that we don't have to wait for complaints to come in. Let's see what feedback there is in the community that we're serving, and actively seek that kind of information, because there may be very simple blockages that we don't know. So I would urge you to do that. My final question, I'm invoking the Moran rule here, Mr. Chairman. Sorry. This won't be the first time. Dr. Baptiste, is the VA listening to you? That's my basic question. You've made a lot of recommendations. Your work, the IG has done a lot of really good work, and I just want to be sure that it's being implemented and that somebody's paying attention. Are you satisfied with implementation?
So in our reviews, we do make recommendations and follow.
That's my question. Are they
Yes.
following your recommendations?
And then we follow the action plans and actions that VA takes to ensure that the improvements are sustained and effective. And in addition, what we would expect is when we conduct an inspection at a particular facility, that leadership at other facilities review our recommendations, review our findings, use that as a tool to review their own programs and make improvements.
I hope you will follow up, because doing reports and studies doesn't matter unless the recommendations are implemented. So I think that should be very much a part of your mission.
We do have a robust follow-up process.
Thank you. Thank you, Mr. Chairman.
Senator Bowles.
Thank you very much, Mr. Chairman. Thank you for holding this hearing, you and Ranking Member Moran. It's so very important. I want to thank the members of both panels for being here today. Your expertise on the issues facing our veterans across the country enables Congress to do our jobs more effectively. You're making the VA and veteran experience better, not just for women, but for all veterans. We need to create a culture at the VA that welcomes women and welcomes women veterans and makes them feel like they belong. It's long overdue that we update the belief that when a woman seeks care at the VA, it's because her husband is the veteran. The great state of Arkansas is home to over 19,000 women and veterans, and I couldn't be prouder to represent them here today. And also I want to thank all of you all for the great job that you do representing them in your own way. Women are currently the fastest growing demographic in both our active duty and veterans populations. Breast cancer is the most diagnosed cancer among women in the United States. The committee worked hard. We especially want to thank Senator Tester for his championing the Service Act. It requires the VA to conduct mammograms for all women who served in areas associated with burn pits, other toxic exposures. Dr. Scavella, can you update us on the implementation of the Service Act at the VA and what issues, if any, you're seeing on the ground?
Yeah, thank you for that question. So we are really proud that we have fully implemented the Service Act. We are providing updates on all of the different sections in the Service Act to make sure that we are responding and meeting the needs of our women veterans. I want to turn it over to Dr. Haskell, who was intimately involved in that work, to provide some details.
Yeah, thank you, Senator Bozeman. So we have been implementing the Service Act actively since, I guess, last year, and Essentially, the way we are implementing it is offering all of the women who served in these areas where they may have had potential toxic exposure a breast cancer risk assessment, and then we would order mammograms for those who it's felt to be clinically appropriate based on their toxic exposure as well as their personal and family history. So what we've done is we have created a templated note in the electronic health record where the providers can conduct that breast cancer risk assessment, and then the note actually guides the provider about whether they should order a mammogram or whether they should refer the woman to some more extensive evaluation and testing, such as seeing a high-risk breast oncologist or another specialist. And so we've not only created the template, but we've also created a dashboard that's available to the field so that the providers in the field can see all of the women in their panels who are eligible for the Service Act breast cancer risk assessment. So it's progressing nicely, and many sites are doing active outreach where they're actually making phone calls to women on those lists in the dashboard to encourage them to come in for their breast cancer risk assessment.
Oh, good. That's a very good story.
Thank you.
Also working with Chairman Tester, we got signed into law the Mammo for Veterans Act, which is a little bit different in that it requires the VA to develop a strategic plan to improve breast imaging services, create a pilot program for veterans in areas where the VA does not offer in-house mammography, expand veterans' access to clinical trials through partnerships with the National Cancer Institute. It also required the IG to report on mammography services furnished by the VA. Dr. Baptiste, I was pleased in your testimony that your investigation did not identify concerns related to access and use of mammograms at the VA. Could you please speak to the findings and recommendations we should expect to see in this report as it will be published soon?
Yes, so
It's not against the rules.
No. Our review found concerns that frontline staff were not aware of the Women's Oncology System of Excellence. I believe VA refers to it as the Breast and Gynecologic Oncology System of Excellence. And so that was one of our concerns and part of our recommendation. The second is regarding the cancer registry. We found that data on veterans with cancer diagnosis were not being entered into that cancer registry.
Okay, very good. So with that, I will yield back.
Senator Blumenthal.
I started to be like Angus and ask a question that ran over, but I'm going to defer to.
You should always try to be like Senator King. Thanks to the chairman and ranking member for having this hearing. Very, very important topic. Thank you for all of your great work on it. We're going to have a witness from the DAV, which recently did a report on women's mental health. Some of their findings are pretty disturbing. I'm sure you're familiar with them. That report found that between 2020 and 2021, suicide rate among women veterans rose 24%. It also found that women are twice as likely to attempt suicide than male veteran. They're 3 times more likely to choose a firearm as a means of suicide, and more than 50% of deaths for women veterans are by self-inflicted firearm injury. Why is that? What can we do about it?
So thank you for that question, Senator Blumenthal. Each time we hear of a tragic case, we are devastated, especially when it's our women veterans. We have done a lot of research and continue to do a lot of research into the area. We do have a women's health research network that does a lot of the analysis post-event to try to help us to inform. We understand that women veterans do have a unique set of mental health conditions, including PTSD, depression, anxiety, that could contribute to this. They typically have a slightly different burden with regards to taking care of families. That also adds to that. We find that our women veterans are younger which is also a risk factor for some of the things associated with both military sexual trauma and intimate partner violence. They tend to be younger, and that may be the reason why they may be in more financial turmoil and not as established. So all of these things contribute to their mental health concerns. That's one issue. The other is because of their training in the military, they are adept with using firearms. They have access to approximately 38% of our women veterans have firearms available to them, and they are using those. So we do have within the Office of Suicide Prevention and the Office of Mental Health, we are looking at managing the mental health issues, and then with suicide prevention, in addition to community partnerships, we have a lethal means safety initiative where we're trying to put time between a thought and an action by having firearms locked. We continue to work with women veterans who have either had suicidal ideation and have not committed an act to try to understand what would help them to potentially not be successful if they have those thoughts again. We're continuing to do many research efforts to look at this.
So they're younger, perhaps more likely to be in financial trouble, victims of sexual assault or other similar trauma, and you're doing more research. How systematic is the research? In other words, do you have ongoing specific studies, or is it a case-by-case kind of?
So I will start, but I will turn it over to my colleagues. So the research is not just following an event. We do have ReachVet, which is using analytics tools to take a look at risk factors for women to proactively reach out to them before they may even know that they may be, at risk. So we're using both real-time tools. This is all on top of an ongoing, very intensive mental health care that they're receiving within either their women's health clinic program or within their mental health clinic. We have integration of mental health in primary care. So there are many things that are going on, and this is just these are things we're doing on top of that, but I want to see if either Dr. Johnson or Dr. Haskell would like to add to my answer.
I think that was really a pretty thorough answer, Dr. Scavella. But I did want to say that, we are very concerned, especially about the use of firearms, and that we have formed a work group between the Office of Women's Health and the Office of Mental Health and Suicide Prevention, and we're looking at several specific ways to really focus in on this, and one is the training about lethal means safety and the gun locks, and training not only for veterans but also for their providers to ensure that all of our women are actually screened for firearm ownership and then given a gun lock if they would like to have one. We also have, for all of our veterans in primary care, they do get suicide screening and depression screening, so that's available as well. And then, the other thing that the work group is focusing on is really ensuring that all of our care in the VA is what we call trauma-informed care, and that's just sort of ensuring that that our providers are aware that any veteran who comes to the VA may have had a trauma experience, and that may impact their engagement with health care. And we know that when veterans use VA, they are less likely to commit suicide than those who are not using VA services. So we want to really encourage our women to be engaged in and follow through with their VA
Can I interrupt you because my time is about to expire?
Sorry.
The numbers of women using VA services has increased over the recent past. Do you have numbers as to what percentage of the women veterans are taking advantage of VA services as compared to the percentage of men, and what the trends are in increased use by women of the VA, those overall numbers?
Yes, thank you for that question. So there are approximately over 6 million active veterans using our services. Of those, approximately 10%, 625,000 to 630,000 are women veterans. We do find that the women veterans who are coming into our system tend to be younger, and also they're also of all different ages, but they're younger, they're in this cohort that we're concerned about.
But what percentage of all the women veterans are taking advantage of the VA as compared to what percentage of all the men? Do you understand my question? In other words,
Perhaps
6 million is what percentage of all the men,
Okay.
male veterans out there, and 625,000 is what percentage of all the women veterans?
Yeah, I can talk about the enrolled. I'll ask Dr. Haskell if she knows about the total in the U.S. Population.
We do follow those numbers. We call it market penetration, would be the, sort of percent that are using the VA compared to the percent that are available in the market. And I would have to get back to you on the current exact number, but I believe it's somewhere around 42, 45% for women veterans and slightly higher for men. But again,
Could you get back to me? I don't want to take the committee's time
Yes.
with it now, and I appreciate your letting me.
Yeah, before
go
we
on a
get to
little bit.
Senator Rono, just to be clear, you're saying 45% of the eligible women veterans are in the VA?
I believe that's true, but
Okay, that's
again,
fine. It could be off a percent or
Yeah,
2 or
we need to
5,
get
it's
back
fine.
to you with the exact
We've got a ballpark
And
figure.
if you could confirm those numbers and get us the most current ones, and then the similar percentage for the male veterans, thank you.
Senator Rono.
Thank you, Mr. Chairman. I'm glad that Senator Blumenthal focused on the incidence of women veterans committing suicide. Whenever any veteran commits suicide, in fact, whenever any enlisted person commits suicide, that is a matter of concern to us. But in particular, it's very distressing that the incidence of women veterans committing suicide is going up, not down. Is that right? That's what it sounds like to me.
Correct.
Yeah. So thank you for citing some of the reasons or some of the circumstances that could lead to their suicide rates. But some of these conditions do not happen once they separate from the military. Are they not experiencing sexual trauma while they're in service? So what is happening within while they're still in active duty that will help when they get into the veteran status? Will help in terms of the support that they get once they're in veteran status. Is there some continuity of services that we provide to women when they're in active duty as well as when they transition to veteran status?
That's a great question, Senator Hirono. I think we would need to look at some of the DoD data related to the penetration. We did see similar trends in women, active service members, but I cannot compare our 24% to theirs. I think there are some concerns that women, some of the things that actually do help them are the connectedness that they have with each other and those bonds that help to actually reduce the risk. But we do need to look at that. I don't have the answer to that particular question. I want to see if Dr. Haskell or Dr. Johnson does.
no, I don't think I have anything to add to that.
So my question is there some kind of a programmatic or other ways that you are already connecting to women service members before they reach veteran status? Is there a program like
I'll
that?
turn it over to Ms. Britton, who has some information based on the work she's doing.
Please.
Thank you, ma'am. So for our VA Solid Start program, we actually target veterans that received a mental health exam within their last year on active duty. In FY24 so far, we've successfully connected with over 136,000 women veterans, actually veterans, but of those veterans, 32,000 of them were identified as priority veterans. There are 3 calls that are made to those veterans within the first year of them exiting active duty. So one within the first 90 days, the second one within 180 days, and then a final call before the 1-year anniversary of their release from active duty. So that is a connection that we're able to make with the VA Solid Start call agents. Those are personalized conversations. We keep them with the same representative for the entire year so that they can gain a level of trust as it relates to the engagement. We do track the the referrals that we make to the crisis hotline. And in FY22, we had a total of 9 female veterans that we connected to the crisis hotline. And in FY23, in FY23, we connected 4. So far in FY24, and this does not contradict the increases that Dr. Scavella talked about, but we have not received any crisis calls from women veterans in FY24 that have needed to be referred to the crisis hotline.
Do you think that, this is not a criticism, but because I think you're doing your best, but do you think that more needs to be done in terms of connecting with the female service members while they're in service?
Yeah, I think we need to explore this to see if there is some type of transition. We do know, just based on other work we're doing, that 1 year of transition between being an active service member to becoming a member of a veteran, being a veteran, that there is a lot of instability during that 1 year, and it's possible that even though we have implemented several programs, that perhaps there's something or some things that we are not providing in support.
So every service, except for the Air Force, is having recruitment issues. So I would imagine that there is an increasing number of women signing up, and I think that we can see those numbers get even higher as the recruitment efforts produce more female recruits. So I think that what you all are doing to identify, well, these are, I'm talking about the people who are in service, but I do see continuity of service kind of an issue that needs to take place. So whatever you're doing in that regard, thank you. I know that historically the medical studies have not particularly focused on the particular healthcare needs of women, and to the extent that VA has particular programs or healthcare programs that reach female veterans, can the VA be a leader in ensuring gender equity in terms of producing the kind of research that would be useful in providing healthcare to women, or particularly female veterans?
Yeah, so thank you for that question. We do have an active women's health research network that is doing a variety of research projects, looking at all things that affect women veterans, the unique needs that they have as they separate, the unique needs that they have as far as different mental health conditions, reproductive health concerns, and all of the things that surround that, as well as those who may have been exposed to toxins, et cetera. So we do have a robust number of research projects ongoing and being published.
Thank you. Thank you, Mr. Chairman.
Thank you, Senator Rono. When I first got on this committee, there was, veterans never talked to me about their doctors. They could always request the doctor they got. That changed sometime half a dozen years ago. I think I got a complaint from a veteran that said, I want to see the same doctor I saw last time I was in, and they wouldn't let me do it. There was a question asked earlier that talked about you could have your clinician of choice for women, and I assume that applies to men. And is that a new policy, or is that, by the way, I applaud it. I think it's the right thing to do. I think the veteran should be able to stick with a person that knows in the VA. When did this change?
So we've always tried to take the considerations and requests of our patients into consideration. There are times when we cannot adhere to the requests.
Yeah, because they're busy.
It could be unethical and et cetera.
Yeah.
But we do try to make sure we're providing our veterans with
Well, I applaud that, okay? Dr. Baptiste, I'm going to tax your memory for a second. The ranking member talked about, what I believe he talked about was an OIG report and how the VA was addressing those OIG recommendations. I think the follow-up he wanted to ask, and the follow-up I'm going to ask, is Ms. Britton talked about what they were doing. I want to know your opinion about what they were doing. Did they address the challenges? And look, I don't want you guys to get into a fight there on the panel. I know you're friends. But the truth is that the IG provides our eyeballs into the VA, and if what they're doing isn't addressing the problem, I really want to know. And if it is, I really want to know.
Sure. So, as you pointed out, our audit division has issued 2 reports
Yes.
reviewing MST claims.
Yes.
And we recognize that VBA has set up these MST operation centers to centralize the processing of those claims. There is one recommendation still open from our 2021 report regarding the review of some denied claims. And we are concerned that there may still be some inappropriately denied claims. Our audit group is planning to review that again in the near future.
And this is a question for you then, Ms. Britton. The review of denied claims, are you guys in process of doing that before they review your review?
Yes, sir. So my staff and I, we actually have met with the OIG staff several times over the last year to review the recommendation as well as the centralization of the MST cases. As it relates to the 9,700 review, there were a little over 90 cases that were identified by the OIG that we needed to re-review. Based on the overturn rate of those 90-plus cases, we actually expanded the review, and we reviewed 9,700 cases.
The bottom line is did it result in any of those denied claims being undenied?
Yes, sir. We have a 62% overturn rate of the re-reviews that we've done, which has resulted in over $69 million.
And has there been a process put in place to make it so that those denial of claims that are bona fide claims don't happen to begin with?
That is the increased training that we've done. So we've done training on the markers, which is an area where we know that specialized experience is required.
Okay, I talked about the Deborah Sansom Act earlier in my opening statement. And we talked about some of the things it could do. I want to, from your eyeballs, Dr. Scavella, what tangible improvements has the VA seen as a result of the measures in the Deborah Sansom Act? And does Congress need to do anything else?
Yeah, thank you for that question. So I do want to turn that over to Ms. Britton because
Sure.
she has been predominantly working on that.
So with the Deborah Sansom Act, we have implemented those recommendations. For Section 5205, which is the recommendation that speaks to the Women's Coordinator, Veteran Service Coordinators. We do have those coordinators at all of our regional offices. For 5501, which is the military sexual trauma conditions, that is related to the MST processing site and the improved training that I spoke about with the markers. We do have implemented as part of a mandatory requirement for our MST, for our examinations, that all veterans are given the option in the examination notification letter to select a gender-specific examiner. And then also with 5503, which is the piece that speaks about the OIG and their review. We did receive over 48,000 claims in FY23. We've completed over 43,000. As I stated earlier, that grant rate has improved over the past few years. From 2011 up until to date, we've seen a significant increase in the grant rate.
Okay, I mean, I think the bottom line here is we all need to be on the same page when it comes to women's health, in particular in military sexual trauma. And in the end, the statistics are really good, except I get lost in them. I just want to make sure that the women veterans are getting what they need when they go to the VA, and they're not being turned away, they're not being hit with red tape, they're being accommodated with the challenges they have. With that, we're going to get to the second panel because they're very, very important also. But I want to thank all of you for your testimony, and you are dismissed, as I would say when I was a school teacher. And we'll bring up the second panel.
Thank you.
I'm going to start reintroducing the second panel now. First up, that's going to testify first is going to be Dr. Alyssa Engel. Alyssa is a Montanan, wears many hats. Dr. Engel is a veteran, a therapist specializing in military and veteran community, a volunteer mentor coordinator for Montana's 8th Judicial District Veterans Treatment Court, and she is a current member of the Montana Air National Guard. We also have Julie Howell, that is an Associate Legislative Director at PVA, that's Paralyzed Veterans of America. We have Dr. Kirsten LaHaye Walsh, who is a Government Affairs Specialist for the Wounded Warriors Project, and Naomi Mathis, the Assistant National Legislative Director for the DAV, the Disabled American Veterans. And we want to thank all four of you for being here today. And as I said, we will start with you, Dr. Engel. Thank you for making the trek from Montana. It is good to see you again, and you may proceed. This Great Falls, Montana, one of the beautiful, most beautiful places on earth. And the four of your entire written statement will be part of the record. I would like to ask you to keep your verbal statement within 5 minutes. Thank you.
Good afternoon, Chairman Tester, Ranking Member Moran, and committee members. Thank you for the opportunity to speak with you all today. I'd like to focus on military sexual trauma in the claims process. It is crucial that MST claims be processed accurately and in a timely manner. The consequences of an incorrect denial are catastrophic. When we have an MST claim filed, we are being handed the opportunity to right a wrong for that veteran. This is a privilege that they don't have to give us, because by that point, they've already been through hell. I touched on the topics of institutional betrayal and moral injury in my written testimony because both play a role in the nature and type of PTSD we see with MST. The inclusion of one or both often results in the development of what we call complex PTSD. A denied MST claim is just another layer of institutional betrayal. Many victims wait to report, if they report at all, until they are discharged from the military, assuming it will be safer or because they desperately need the resources. When their claim is denied and they're left feeling betrayed, worthless, abandoned, and unsafe all over again, and the institution that should be helping and protecting has just further complicated their trauma. Conversely, having a claim approved is a powerful healing tool. It's the equivalent of a guilty verdict in court. It doesn't eliminate the trauma memory, and it doesn't heal the trauma reactions, but it also doesn't compound the trauma, and it lays a priceless foundation for healing. A validated disability claim tells the victim, we believe you. What happened to you wasn't your fault, and it shouldn't have happened on our watch. It tells the victim that as a nation, we truly are grateful, and that we will stand beside them. Given the current MST claims processing procedures, we cannot look at our women vets in the eye and honestly tell them that we believe them and will provide them with the services they need to heal. We must enact the necessary changes to create an impeccable trauma-informed claims processing procedure. When I accompanied the Marine veteran that I referred to in my written testimony to her claims appointment with the VSO, she couldn't focus, she froze, she didn't remember what was discussed in the meeting. This just illustrates how complicated and terrifying the process is, how trauma instinctively throws the veteran into survival mode and shuts down the brain's ability to manage such a complicated process. It's also very difficult to prove MST when most victims don't report, they don't seek medical care, and they don't tell anyone for years. Neither of the women veterans I spoke about in my written testimony reported their assaults to the military. They do not have DOD documentation to substantiate their claim. They have their story that they've told to maybe one or two people and a fragmented memory. That's how sexual trauma works. If you sit with someone who trusts you enough to tell you their story, the pain and betrayal are palpable. But earning this level of trust takes time. The current claims process doesn't allow examiners the luxury of time. They see a veteran who enters the exam room in pure survival mode one time. The examiner might be a male, they're in a sterile and foreign meeting space, and they are asking questions about the worst moments of that veteran's life. It's impossible to get an accurate determination under these circumstances. The VA must find a better way to substantiate MST claims. Why do we presume dishonesty until proven otherwise? What if we created our processes based on research, which gives us an overwhelming amount of evidence that victims tell the truth? The consequences of denying a valid claim are far greater than the consequences of approving the very rare false claim. In addition to improving MST claims processing, we must also fix the referral and authorization system. When a woman veteran is ready to engage in mental health care or care related to other MST injuries, it is imperative that they have easy access to a network of highly trained professionals. In grad school, I invited the dean of the law school and the director of the veteran law clinic to sit on my dissertation defense committee. It's pretty risky business to invite a lawyer to ask you as many questions as they want about your research. But she only asked me one, and it will haunt me forever. She told me that her high school-age daughter was interested in going to the Air Force Academy and that she had a very competitive application. And then she asked me if I thought she should encourage it. And my answer was, I don't know. Which is also the answer you really don't ever want to give in a dissertation defense, but it was the honest answer. With the MST epidemic raging and the aftercare lacking, I can't in good conscience encourage anyone to send their child to basic training. My hope is that in the very near future, thanks to the good work of so many, I'll be able to say yes, absolutely. The military is a wonderful career path for your daughter. Thank you for your time, and I welcome any questions.
Doctor, thank you. There will be questions. Julie Howell.
Chairman Tester, Ranking Member Moran, and members of the committee, Paralyzed Veterans of America thanks you for the opportunity to present our views on the current state of care for women veterans. Few veterans understand sorry, I'm getting choked up from yours. Few veterans understand the full scope of benefits offered by VA better than PVA members. Ensuring the women members of PVA have timely access to quality care will help VA be better positioned to deliver care for all veterans, particularly those with complex illnesses and injuries. We've all heard that women are the fastest growing demographic or the fastest growing cohort of veterans using the VA, accounting for nearly 30% of all new VA enrollees. It is our obligation to ensure that all women veterans encounter barrier-free access to health care and benefits. We commend Congress on several legislative victories for women veterans over the past few years, such as the MAMO Act, the Service Act, the MST Claims Coordination Act, and the Deborah Sampson Act. Collectively, these bills represent a huge investment in women veterans. However, as we all know, there's still plenty of work to be done. In our written statement, you will find several topics that we believe need additional attention. But in the interest of time, I'd like to focus on a few areas that are of the utmost concern to PVA. The Deborah Sampson Act was a major achievement that became the vehicle to draw attention to the deficiencies encountered by women veterans when accessing VA. While many women veterans have benefited from its passage, it's had little impact on PVA's women members. VA still lacks critical accessibility accommodations that our members rely on. Barriers for our women members that they encounter when accessing gender-specific care are an issue, and VA needs to take them seriously. It starts with parking lots with limited disability parking, check-in counters that are too high, waiting and exam rooms that are too small, limited ceiling lifts, and a general lack of accessible medical diagnostic equipment. This is why we support the Veterans Accessibility Advisory Committee Act to ensure that VA prioritizes accessibility for all of our disabled veterans. I'd also like to take a minute to discuss the very sensitive issue of military sexual trauma. MST is pervasive, and we must do everything we can to treat survivors with the utmost care and respect. Mr. Chairman, in a 2021 survey of our women members, nearly 40% of them reported that they had experience with MST. 40%. Now, a provision within the DSA mandated that survivors could pick the preferred gender of the providers they engage with. However, we are hearing from our service officers that that is not always offered, and that is not standard across the board. Many of our members are filing their MST claims decades after their experience. And for SCID veterans, some of those physical long-range symptoms of MST are incapable of manifesting. However, that doesn't make their trauma or their experiences any less real. VBA staff need to understand the nuance that comes with working claims for veterans with complex injuries. We thank Chairman Tester for the reintroduction of the Service Member and Veteran Empowerment and Support Act of 2023, which we believe may help address some of these concerns. Finally, when people imagine a disabled veteran and their caregiver, most people imagine an older male veteran with his wife by his side. So in contrast, I would like to introduce the committee to Ann Robinson. Ann Robinson is an Army veteran, a PVA National Vice President, a wife, a mother, a grandmother, and my friend. Anne was injured in a military vehicle accident in 1999, and Harry has been her dedicated caregiver and loving husband ever since her injury. Anne's level of need is significant, and while Harry has constantly been by her side, they need additional help. Recent expansions of the Veteran-Directed Care Program have provided Anne an opportunity to hire direct care workers. However, it hasn't been that easy. The VDC program only allows Anne to pay her workers around $19 an hour, and after more than 100 interviews, the few folks that were qualified and hired left for higher-paying jobs. In her home of San Antonio, the staff she needs generally earn upwards of $35 an hour. The lack of direct care workers is a nationwide crisis, one that hits disabled veterans with the greatest support needs quite hard. Our nation must increase efforts to grow this workforce, and VA needs to help by ensuring veterans with catastrophic injuries and illnesses are able to secure needed direct care workers in line with market demands. In closing, we commend the committee for working toward the passage of the Elizabeth Dole Home Care Act. PVA members are eager to see this bill become law. We urge Congress to pass this as soon as possible because our nation's most vulnerable veterans should receive care in the comfort of their home should they choose. Many argue that this level of care costs too much. However, in recent years, we've talked a lot about the true cost of war. Anne and many like her have earned their benefits. The lifelong supports that they need are the true cost of military service. Thank you to the committee for giving PVA this opportunity to share our views, and I'm happy to answer any questions.
Thank you, Julie. If we can't take care of our veterans when they come home, we shouldn't send them off to begin with. Kirsten, you're up.
Good afternoon, Chairman Tester, Ranking Member Moran, and distinguished members of the committee. On behalf of Wounded Warrior Project, I want to thank you for the opportunity to speak before you today about how Congress, VA, and the wider community can better support women veterans. Since 2003, Wounded Warrior Project has been working to transform the way America's injured post-9/11 veterans are empowered, employed, and engaged in their communities. For the past 20 years, we have supported warriors through and beyond their transitions to civilian life with services in mental health, physical health, peer connection, career counseling, and financial wellness. We currently offer these services to over 200,000 veterans across the country, and we are welcoming hundreds more every month. And as key context to today's hearing, I want to briefly highlight how we are serving more than 35,000 women warriors. We have taken deliberate steps through our Women Warriors Initiative, which supports these veterans through tailored programs and services, such as women-only peer support groups or culturally competent mental health care that can be offered in gender-specific cohorts. Through our physical health and wellness program, we offer female-focused opportunities such as multi-week courses that provide education on topics such as perimenopause and postmenopause challenges and experiences. And in fiscal year 2023, more than 5,000 women participated in our connection programming to build bonds with other veterans in their areas, and over 130 women stepped up to serve as warrior and peer leaders in their local communities. Most notably for today, I am pleased to share insights we gained through the development of our 2023 Women Warriors Report. The report serves as a beacon, shedding light on the experiences, struggles, and triumphs of our women veterans. While our written hearing statement includes more perspective, I'd like to highlight 3 of our key focus areas in the Women Warriors Report and to provide insight into the policy recommendations we developed through our data. First, the report highlights the critical importance of mental health support for women veterans. Anxiety is the #1 injury or health problem reported by women warriors, and like PTSD and depression, is reported at a higher rate than males. But while women warriors are also more likely to report moderate or severe mental health symptoms, they are also more likely to seek support and care than male warriors. It is incumbent upon us to expand access to mental health services, to meet the warrior where they are, destigmatize seeking help, and foster a culture of care and compassion within our veteran community. Congress should continue to help VA retain, recruit, and train mental health providers, and continue oversight to ensure VA is creating community referrals for care if it cannot provide timely services itself. We also encourage the committee to consider broader issues, such as women veterans not feeling respected within their communities, which can lead to feeling isolated, left out, or lonely, all of which were reported as top issues for women warriors. A second central focus of the report pertains to healthcare access and quality. Women warriors are more likely to navigate the VA system, with 3 in 4 using VA medical centers for primary care. However, only 61.9% use VA for women's health care specific services. In recent years, women veterans have often cited feeling harassed at VA medical facilities, which has dissuaded use by many. But VA has worked hard in recent years to ensure women veterans feel safe and appreciated while accessing health care. Another challenge presented was that more than half of our women warriors reported delaying or putting off getting health care, with barriers including a lack of cultural competency from providers and staff. This issue is especially important for individuals who have survived MST. With over 2/3 of our women warriors experiencing sexual harassment while in service, and more than 2 in 5 reporting having experienced sexual assault, it is imperative that VA support services through the benefits process as well as through health care. More broadly, from accessing gender-specific care that is culturally competent to feeling listened to by providers and staff, there is a critical need for tailored, comprehensive benefits and healthcare initiatives that prioritize the well-being of our women veteran population. A third focus centered around the financial wellness for women warriors, which included topics such as career advancement and leadership opportunities for women with a military background. Despite being more educated, women warriors face greater struggles with employment than males. With 1 in 10 women warriors reporting unemployment, we've heard many stories about adverse factors like a lack of professional mentorship, difficulty translating military skills to the civilian workforce, and finding employers who are supportive. Congress can help take proactive steps to address issues like these by continuing to invest in workforce training and education initiatives, such as the Edith Norris Rogers STEM Scholarship and Vet Tech programs. Both have a high potential to benefit women warriors specifically. In the coming days, weeks, and months, we look forward to continued discussions with leaders, VSO partners, and the broader community, along with opportunities to translate the insights and finding of this report into tangible initiatives and concrete action. We are steadfast in our commitment to our women warriors, ensuring that they receive the respect, recognition, and support they so rightfully deserve. Thank you again for the opportunity to testify before you this afternoon. I look forward to answering any questions you may have.
Kirsten, thank you for your testimony. Naomi, you have the floor.
Thank you. Chairman Tester, we appreciate the opportunity to discuss DAV's new report, Women Veterans, The Journey to Mental Wellness. Our report comes on the heels of VA's most recent veteran suicide prevention report, which showed overall increased rates of suicide for veterans. However, the most alarming finding was that the suicide rate among women veterans jumped more than 24% in 2021. That's nearly 4 times higher than the increase among male veterans and vastly higher than the increase among non-veteran women. Our report looked at the unique risk factors contributing to the staggering rate of suicide among women veterans and the challenges and obstacles women veterans face on their journeys to mental wellness. DAV offers more than 50 legislative and policy recommendations that have the potential to save the lives of women veterans. The issue of lethal means safety is especially important as firearms were used in more than half of women veterans' suicide. In fact, the rate of women veterans dying by firearm suicide was nearly 3 times higher than for non-veteran women. VA has included women veterans in its lethal means safety campaigns. Unfortunately, some women veterans felt the ads did not make clear why it was so important to keep their firearms safely stored. DAV recommended the VA should conduct additional focus groups with women veterans to determine the most effective, secure firearm storage messages and messengers for this population. We also found that military sexual trauma, MST, and interpersonal violence, IPV, led to an increased risk for suicidal ideation and self-harm behaviors among women veterans. 1 in 3 women veterans enrolled in VA care report experiencing MST, and 1 in 5 women veterans using VA primary care reported experiencing IPV or domestic assault. For these reasons, DAV strongly recommends that MST and IPV be a central pillar of VA suicide prevention reports. Research also shows there is a direct link between trauma and substance use disorder, as well as eating disorders, which often stems from an attempt to control chronic pain or to cope with post-traumatic stress. The risk of suicide death among women veterans with active substance use disorder is more than 2 times the rate of male veterans. Unfortunately, most women veterans with at-risk alcohol use are not in treatment, citing stigma and discomfort with mixed-gender programs as reasons for not engaging in treatment. We found geography and barriers to accessing mental health care can be another risk factor for suicide. Research shows that there is a 20% increased risk for suicide among rural veterans. Mr. Chairman, as you know, 1 in 4 women veterans who use VA healthcare services live in rural areas, and rural women veterans have higher rates of suicide by firearm than their urban women veteran peers. Perhaps the most underappreciated aspect of women veterans' health is the relationship and impact of reproductive health issues on mental health. During the life cycle of women, pregnancy, birth, and menopause can bring about significant hormonal shifts and increase the possibility for mental health issues, including increased risk for postpartum depression and poor mother-infant bonding. I know firsthand how dramatically pregnancy can impact a person's mental health. Following my service in Iraq, I was diagnosed with PTSD. Later, I became pregnant, and medical complications forced me to give birth to my son 2 months early. Subsequently, I began experiencing severe postpartum depression. One day, while my baby boy was sleeping on the bed, I started having terrible, intrusive thoughts that threatened to harm both of us. This served as a wake-up call for me, and I quickly got the mental health care I needed. While I was fortunate to get the right help to get through my crisis, many women veterans are not even aware of the powerful impact hormonal changes can have on their mental health. In conclusion, the successes and gaps in DAV's report highlight the importance of continuing to invest in VA women-centered research programs and services and targeted suicide prevention efforts. Mr. Chairman, this completes my statement, and I look forward to answering any questions the committee may have.
I appreciate all of your testimonies. Thank you very, very, very much. And I will start with Senator King, if you have questions.
I do. All of the discussion today has been treating MST and its ramifications and implications and the terrible toll that it takes. But I'm sitting here saying, shouldn't we be doing more to prevent it from happening in the first place? Am I correct that the figure is 1 in 3 female veterans report military sexual trauma? That's unacceptable. And I know I also serve on the Armed Services Committee. We've had a lot of work over the last 10 years, led by Kirsten Gillibrand, as you know, on changing the rules and the regulations. But it seems to me we're really talking about a culture change, that this kind of conduct is just unacceptable. But your testimony has been very powerful, and I agree with everything you said about better treatment, more than one interview, more training. But Mr. Chairman, we also, Mr. Chairman, he's chairman now. I'm the chairman, okay. Well, in that case, no, but we really have to keep, I hope you'll work with us, with my office, on dealing with these issues, not only here, but in the Armed Services Committee. Because if there's more than we can do, let's do it. But the hardest thing is culture change. But I remember many years ago when drunk driving was an epidemic in this country. And it became not cool sometime in the 70s and 80s. And now the level is much reduced. It was a culture change. And so we need to be thinking about that. Ms. Howell, you talked about outreach. Suggestions for improving outreach. You heard my questions of the prior panel. What can we do specifically? Better contact at TAP? What is it going to take to get more women veterans into the system where help is available?
Thank you for that question, sir. The work that VA is doing to get the word out in TAP is great. That's also a very small portion of the veteran population. Most veterans engage with VA several years after they've already separated. That's the way this usually works. They engage with all the support services years
yet,
after.
One of the most dangerous periods is the
that
immediate
transition.
Post-separation.
If I may just take a second, sir, one of the questions you asked to the first panel was, how come such a few like, why such a small percentage of women veterans are actually engaging with VA? What do we need to get them there?
Exactly.
But then you also just answered your own question in that this trauma happens at DOD, and then we expect VA to fix the problem. Women are not going to, many women are not comfortable going to VA because what happens when you run into a bunch of people that you then assume are a danger and a threat? Like my neighbor commented earlier, women are not a monolith, no veteran group is. We need various channels to be able to create a net so that all of those outreach efforts can align. You can do your standard, let's go have 140,000 touch points with veterans throughout a year, but if you're not engaging with the local communities that those women feel comfortable in, you're gonna miss those folks. We can't spend all of our time, while yes, it's absolutely critical to focus on transitioning service members, plenty of MST claims come in decades after these women serve. We don't feel comfortable addressing that concern in the moment. It's a trauma response, as was said earlier. So we can't think that any one outreach method is going to be an encatchment for all veterans.
Well, to the extent you all have ideas along this, we don't have to do it all right here. Be in touch with us, with the committee, with the chairman, with my office, because the most valuable commodity around here are ideas. And you're in touch with the field to tell us what can be done, what the steps are. One of my problems on armed services since the very beginning of my tenure here is that I believe that the Defense Department should spend as much time, money, and effort on transition out as they do on recruiting in. And we're looking for all kinds of ways to improve the handoff. For example, by notifying the state veterans officer when somebody is going to be coming out and going to their state. So a lot of those rules, but please give me as much help as you possibly can. Your testimony has been very sobering. Dr. Engel, you talked about the process. I like the idea that one interview is not enough. Is the process improving? I don't want to be like your dissertation.
I was thinking that. I don't think so. I don't think that MST reporting process is improving.
Well, tell me how. You don't have to tell me now. My time has expired. But we have this little digital clock in front of us that governs our life. But seriously, don't let your input to this committee end today. If you have thoughts how to improve it, require 2 interviews. Ensure that there are female intake officers. What should the criteria be? What is the standard? All of those things. Help us to understand that because we may be in a position to fix it.
Yes, sir.
Thank you. Thank you all very much. Your testimony is very important. I really appreciate it.
Senator Hassan?
Thank you, Mr. Chair, and I just want to echo what Senator King just said. Your testimony is really, really important, and it also can be really, really hard. No matter how practiced you get at this, sharing personal details and wearing the experiences of so many other veterans who you're speaking for today is a hard thing to do. So we are really, really grateful to you for that. I wanted to start with a question to Dr. Leahy-Walsh. In its 2023 Women's Warriors Report, the Wounded Warrior Project discussed several difficulties faced by women veterans, including a lack of support as they transition from military service to civilian life. So you discussed this in your testimony, and you mentioned that many women warriors are more likely to experience loneliness, isolation, and a lack of respect for their military service as compared to their male peers. As more women veterans leave the military and enter civilian life, one of the strongest ties to their service is their connection with the VA. So, Doctor, what can the VA do to help address the loneliness, isolation, and other issues that women veterans disproportionately face?
Thank you for the question. We have several recommendations in our report. that we believe would address certain aspects of connecting women veterans to engage more with their community. We have also made recommendations specifically around increasing eligibility for scholarships, because we also see a lot of women veterans and women warriors specifically that are wanting to pursue higher education.
Okay.
But I would say specifically there is a recommendation in our report that focuses around building out a professional mentorship network. A lot of women veterans feel that they have to compete amongst other women veterans while in service. So when they get out, they don't have a net to fall socially. Many women warriors in our focus groups last year also spoke about the need to separate their civilian friends from their military background friends. They didn't want to commingle or intermix the groups. So providing a professional mentorship network would allow women veterans who have achieved career milestones to support those in the transition process, and it would be facilitated by VA. We believe that program potentially would not only increase productivity within connectivity, but also would stimulate further conversations about what women veterans can do to support each other on the outside.
Thank you. That's very helpful. Ms. Howell, in your testimony, you discussed some of the challenges that women veterans with spinal cord injury and disease face. You specifically discussed how difficult it is for these veterans to receive gender-specific care through the VA spinal cord injury and disease system because of the high level of coordination required between this system and the VA's women health clinics. You also stated that many women's clinics are not physically accessible for paralyzed women veterans. So what can the VA do to make care more accessible and more effective for women veterans with spinal cord injury and disease?
Thank you for that question, Senator. I think what is true of all things within VA, particularly around gender-specific care, is coordination. VA is very siloed. Most of us up here are VA users. One of the very unique things about VA as compared to like community care writ large is that there is that continuum. Your doctors are tracking. Everyone's got access to full records. You don't have to necessarily be proactive about that outreach. However, within VA, for women that are using the SCI centers, that coordination is very hit or miss. It relies on a coordinator to be in the SCI center that's willing to take the time to build those relationships. You need a women's health clinic or a gender-specific provider that has the bandwidth to go over to the SCI unit, because more often than not, the women's health clinic is going to lack those fundamental accessibility requirements that keep our women members safe. And so that cross-team coordination, that takes a lot of bandwidth and it takes a lot of effort, and sometimes it takes an external pressure to make sure that people are making those connections so that the PVA women members can receive accessible gender-specific care, either in an accessible women's clinic or through the SCID center.
Okay. Thank you very much. And Mr. Chair, I yield my time.
Yep, thank you, Senator Hassan. I'm going to start with you, Dr. Engel. I share many of your concerns about the military sexual trauma claims process, and would like your input on a change that may help ease the process for survivors. When so many sexual assaults go unreported in the military, it is my belief that we need to require the VA to consider non-DOD evidence. Check out those sources when reviewing claims for all MST-related mental health conditions. I'd like you to comment on that. I would like you to tell me if this could potentially change the impact for MST survivors, or if this is not something that's worthwhile.
Thank you for that question. I absolutely think that that would make it better for survivors. Like we've talked about, they typically don't report, or they report after a large amount of time goes by. And when they do report, it tends to be people that they're close to, their spouses, their friends, their family, not the formal channels. So if we allow non-DOD proof, it really opens up the door there. The other piece about that is when we're looking at trauma-informed care, we always want to give the power and the control back to the veteran that was taken from them. And right now, they're kind of put in a position where I get my disability claim for my MST, but I have to do these things that I don't want to do, or I don't get my claim. By doing what you're suggesting, sir, it gives them more power and control. They get to choose what evidence they want to bring instead of having to produce certain evidence.
Okay, thank you. I'm grateful for the support of all the VSOs that are up here today for the Service Members and Veteran Empowerment and Support Act. I appreciate that. It would expand evidentiary standard for MST claims and make improvements in that claims process. So thank you for that, because if we want to do right by MST survivors, we need to give them a stronger voice, a stronger voice in this process. So this is for the PVA and War Warriors and DAV. Can you each take a moment to describe the impact this bill would have on MST survivors and their access to VA health care and benefits? You can go in any order you want.
Thank you for that question, sir. DAV strongly supports this legislation. In fact, we did a grassroots campaign on it, which resulted in over 22,000 emails from our members in support of this bill. And this bill will help ensure veterans are aware of access to care and services for conditions related to their trauma, and they don't face unnecessary hardships throughout the claims process.
Again, thank you for the question. We have found that women veterans are actually more likely to include more non-direct evidence, which include the work performance records, the financial documents demonstrating unexplained financial situations. So because of that, we, and many other things, we support strongly the SAVES Act. We also are very supportive of ensuring that all Guard and Reserve members are able to receive MST-related services, including mental health care, which is also a provision within this bill, and we very strongly support that.
Julie?
Thank you for the question, sir. I just want to highlight that nearly 36,000 service members reported sexual assault in FY22, according to DOD. And as we've already discussed, that's only the reported ones. I think that your piece of legislation will be critical in making sure that when veterans come forward with their claim, that they don't feel the need to provide the textbook evidentiary support. I think that will provide a comfort level for people that are applying for these claims that will see an increase in applications. I also think for PVA in particular, Section 206 will have a really profound impact. The study on training and processing of claims, PVA believes that critical information can be gleaned from the process by that section in particular. And as I mentioned in my testimony, the complications that come with veterans with complex injuries and comorbidities when they're filing an MST claim, a lot of those long-range physical manifestations don't necessarily manifest with our membership. So I think being able to present that case with the evidence that you have will go a long way, and that study will show whether or not VBA is sticking to it.
I'm going to ask a few more questions, and I'll get to you, Senator King, if that's okay. Naomi, I want to talk to you about something on a personal level and on a more general level, and this deals with mental health. You talked about in your opening statement the impact of childbirth had and the thoughts that went through your head, but something happened and you went and got help. Have you ever thought about why that occurred? Was it because of your association with DAV? Or was it the fact that you've got somebody that knows you well enough to understand when there was a challenge? Or talk to me, because sometimes this doesn't happen and you don't get help, and then it's like any other health ailment. If you don't get help, it gets worse. Talk to me.
Thank you, sir. I would say at the time I was in acute PTSD. I was in the throes of PTSD after coming back from Iraq as a combat veteran, and dealing with that, and then the hormonal changes with having my child, along with polypharmacy. I was on several medications. They were trying to figure out how, which medication would actually work for me. And as that incident happened, it just scared me. In what I would potentially do to both of us, and so. It wasn't really anything specific. It was just myself just trying to will myself out of it and really crawl up out of that hole that I was in.
Yeah.
And my ability to reach out and say, hey, something's not right. This
Yeah.
is not okay. I'm scared.
Yeah. And you were able to get a hold of somebody that could
I
actually
was
help
able
you.
to get a hold of someone, and that's why peer support
Yeah.
is so important.
Yeah. Yeah.
And social support. It's really a protective factor when it comes to suicide prevention.
100%, and I think it's one of the reasons you see a 20% higher rate of suicide in rural America, because isolation is something that happens automatically if you're living where there is no people. I just want really quickly, and I'll get to you, Angus. Half the suicides committed by women, did I get this right, are done with guns?
Yes, sir. More than 50%, actually.
Okay, and the rate has went up by 24%, at least that's what the 2021 study said. I'm a farmer, okay? I'm not a mental health professional in any sense of the imagination, but I have always been told that suicide by guns with women is rare.
In fact, and I'm not a doctor either, but from what we found, it's generally they generally use medication,
Yeah.
or so overdoses or strangulation is the
Okay,
usually.
so the question here is this something that's outside the norm for veterans?
It seems to be, yes, sir. It seems to be that veterans, that is
For women veterans?
for women veterans, that is the method that's chosen compared to their non-veteran peers.
Yeah, and I guess it probably takes somebody, I mean, maybe it's familiarity, but oftentimes familiarity with guns will make it so you don't use it, but maybe not. I could be wrong.
Which is why it's important, sir. There is a time between the thought of
Yes.
suicide
Yeah.
and having that accessibility and actually potentially taking their life by a gun.
It's interesting you say that, because about a month ago, I had a gentleman in my office, a guy, a veteran, that tried to commit suicide with a gun and the bullet didn't fire. And he immediately went and got help, and he's alive today because the blunt instrument didn't work. And he's living a great life, by the way, living a great life, but he went and got help just like you did. And the problem, it can be fixed. The stigma needs to be taken away so that people understand this. Angus?
Thank you, Mr. I just want to be sure in our discussion here to get on the record that I suspect there's nobody in this room who wants to fix these problems more than Dr. Scavella. And everyone I've worked with at the VA care deeply. They wouldn't be there otherwise. And so I don't want to leave hanging that somehow the VA, they don't care, they're too bureaucratic. The VA people I've worked with at the C-Box in Maine, at Togus, the Veterans Hospital in Maine, they're people who are there by choice. So I just wanted to be sure, Mr. Chairman, that was on the record. The 4 women who preceded you care about this issue deeply, and what we need to do is come together to share experiences and find solutions. So thank you for that, and I want to thank our prior panel as well. Thank you.
The only thing I would add to that is not only the 4 women who work for the VA, but the woman who works for the IG cares about it too. And thank you all for your testimony today. I very much appreciate you guys taking the time to be here to talk about this very, very important issue. This isn't the last time, by the way, we're going to deal with this. We're going to be having a roundtable that includes more veteran service organizations, more people's perspective, because I think this is an issue that we've got to continue to find a solution for, because honestly, it's a bad deal. And I would say this, Angus, you talked about training to get out of the service. I think if the military started doing that, it would help their recruitment greatly. I just don't think there's any doubt about that. So I want to thank the witnesses for testifying. We will keep this record open for a week for comment. This hearing is now adjourned.